Good evening, everybody. It is a pleasure to be here in Mumbai. This is about my 5th visit to Mumbai because I like it very much. I'll tell you later why. Meanwhile, I'm going to address the subject of ovarian carcinomas. And I will start by thanking Dr. Amita Maheshwari, who thought that I would be able to convey in 20 minutes all you should know about ovarian carcinomas, okay? Even if I am a pathologist and you are clinicians, and I will try to discuss pathology, but not like a pathologist, but like a clinician or a researcher. All right, so at any rate, let me start by moving this here. Okay, got it. And dim the lights a little bit by telling you from the general to particular that we're going to discuss ovarian, malignant tumors of the ovary. And malignant tumors of the ovary, over 90% of them are epithelial, are carcinomas. Because then the others, much less common, germ cell tumors, 3-4%. Malignant germ cell tumors. I mean, the most common tumor of the ovary is a dermoid cyst, a germ cell tumor. But that's not malignant, it's a mature teratoma. And then ovarian sex cord tumor, just mentioned granulosa, could be malignant, low-grade malignancy, and metastasis. But when we talk about cancer, carcinomas, malignant epithelial tumors are number one. And I should start by telling you that the ovary, the normal ovary, doesn't have any epithelial cells. Does it? No. The ovary is covered by the peritoneum, which is a very thin layer of, let's call it mesothelial, not epithelial, right? Because underneath there's a mesenchyme, and the mesenchyme differentiates into epithelial cells. Okay, here's the ovary, one ovary, two ovaries. The peritoneum covering, and then there is an invagination on each side that eventually closes and forms the Mullerian ducts. The fallopian tubes fuse in the center, the corpus, the cervix, the vagina. That is epithelial, okay? And Mullerian. But the ovary, no epithelial cells. And then when we ask, well, how come all the most common malignant tumors of the ovary are epithelial, are carcinomas? You say, because the ovary is a neighbor of this Mullerian duct, and when the surface of the ovary, which is covered by mesothelium, right, becomes neoplastic, then recover this potentiality of the Mullerian duct and differentiates along the fallopian tube, serous. Endometrium. Clear cell, secretory endometrium. Squamous, vagina. Vagina, squamous. Mucinous, cervix. Okay? You get it. So, that's the way we were told. That was many years ago when I had a lot of hair. And, but now we would say stem cells are the one to blame, right? Stem cells in the surface of the ovary are capable of differentiating along fallopian tube, endometrium, and all that. Okay? So you got the picture. It's a very important controversy nowadays, you know. They say, all ovarian tumors come from the fallopian tube. I mean, this is like HPV vaccines saying, it's absolutely useful for cervical cancer. I mean, well, we'll see. But, everybody says, the same thing with the fallopian tube. Everybody says it's coming from the tube. It's not coming from the ovary. Maybe some, but not all. Okay, let me get back to this and tell you that many years ago, ovarian cancers were classified by cell type. And I told you already that if the cells were like those of the fallopian tube, serous, which is, by the way, the most common epithelial tumors of the ovary, benign, and then malignant. And then if it mucinous, when it resembles endocervix. As a matter of fact, no. It resembles stomach, mucinous, intestinal, or gastric. Why? Because these tumors probably are germ cell tumors, but from a practical purpose, you classify them with the serous, mucinous, right? And then endometrioid, they are like cells of the endometrium, clear cell, transitional when they simulate or they mimic the bladder epithelium, and squamous, mixed, and undifferentiated. These are the types. Okay. But the most important classification, the one you got on the right? Most of these epithelial tumors are benign, but of the non-benign, 1/4 and 3/4, 1/4 is called the so-called borderline, which I think is a perfect term for describing a tumor that shares features with cancers, but does not invade. You see what I mean? Proliferates, but it doesn't invade. And it is borderline clinically, pathologically, and biologically. And then you got the carcinomas, which are the invasive, right? The malignant. So that's the picture of the classification. And let's move on. I'm going to try to convince you that, as previous speaker said, ovarian cancer is not one. Ovarian carcinoma, not one. At least 5. There are more than 5. But the important ones are 5. And I'll list it here, so you can count with the finger of your hand, right? Serous high grade, that's by far the most common, 70 or 80%. And then, much less common, you got serous low grade, clear cell, endometrioid, and mucinous. And I'll go discussing each of them, telling you the peculiarities of these tumors, trying to convince you that these are different diseases, totally different diseases. High-grade serous, low-grade serous, mucinous, endometrioid, and clear cell, totally different diseases. This is the pie. You see, I already said that's high-grade serous, 70%. And then endometrioid and clear cell, about 10-15% each. And then much less common, low-grade serous and mucinous. And then you have a fraction of unclassified. Now, you are not pathologists. And this is a histopathological picture of each of the 5 tumors, types, right, of carcinoma. Now, the first question is, do they look similar to you? No. You know why? Because they are different. Because they are different diseases. Morphologically, clinically, biologically, okay? So this is a morphology, but morphology is very strong. There are 2 things in medicine that are very strong, clinical, and morphology. And then you can put the music, all the mutations, and you name it, everything. But morphology and clinical features, this clinical-pathological relation is very strong. And that tells you that the one up here in the left upper corner is a classic high-grade serous carcinoma. Look at the nuclei, enormous, right? The abnormality of the nuclei. And this is a chaotic tumor because P53 is out of business and BRCA is out of business, so no repair. And if there is any repair, you give these PARP inhibitors, right? And this is beautiful for platinum, right? Because you give platinum and you destroy the tumor. Whereas the low-grade serous is not chaotic. It's a very well-differentiated tumor, so well-differentiated it doesn't respond to chemotherapy. And notice the difference between the nuclei, this humongous nuclei, and this very small nuclei. The music is different. Here is not P53, BRCA, no. Here is RAS and RAF. It's like a valse. This is like hard rock, the one on the left. And the mucinous is like a gastrointestinal tumor, right, colon, with RAS again, and new, ERB2. And then you have endometrioid. What is endometrioid carcinoma of the ovary? Exactly the same as endometrioid carcinoma of the corpus, because it's the same. Menstrual reflux, and then cells implant in the ovary, you have endometriosis, you have the same. And they say, is synchronous or metastatic? You know, that's a question. And the patient survives, so it's not metastatic. Maybe metastatic at the time of reflux. That's metastatic, right? But the tumor is identical to the one you have. I'm talking about ideally endometrioid carcinoma in the ovary. In the corpus, they are separate. Even if they share, even if they have identical oncogenes profiles, they are independent, right? because they arose from cells or stem cells that carry the same thing. All right, and then finally the mysterious. Oops, the mysterious tumor, sorry. I don't know what am I doing here. The mysterious clear cell, the enigmatic clear cell. Now we know more about the clear cell than 5 years ago. And so just to go on, I mean, here are 5 tumors that have different risk factors and precursor lesions. For instance, BRCA and endometriosis, right? For high-grade serous and clear cell or endometriosis. Different patterns of spread. What do you find, low-grade, high-grade serous? Stage 3, right? Advanced stage. What do you find, endometriosis? Stage 1. Different pattern. And then molecular genetic alteration, totally different. Different music, right? And then response to chemotherapy, different, and outcome different. What else you need to call these different diseases? Okay, now, soft. Start with the serous. I'm going to go fast because you know all these things. Well, all I am doing is just putting them in the right place to get the picture, the picture. Now, high grade started with BRCA. You know that the risk was BRCA1, BRCA2 is for the ovary 65%. I mean, the lifetime risk is 30, 60% for BRCA1 and 15, 30. And then hereditary cancer, quote unquote, because it's mutation, but it's inherited, the HNPCC, the Lynch, right? Mismatch repair, which is small fraction compared to the endometrial carcinoma of the corpus, right? Okay, so started with BRCA, the story of the and what happened is that in Holland, when they start doing these wrist resections, salpingoforectomy, they pay attention to the tube. We usually, pathologists, don't pay attention to the tube in the past. Just cut the tube like this and forget it. But they pay attention to the tube, and they found exactly this. Exactly carcinoma, high grade, but confined to the tubal mucosa, identical, sharing the same molecular features like P53, WT1, P53, the mutation, Ki67, identical, but not invasive. And they call it carcinoma in situ. No, it's not carcinoma in situ. Why? Because it's carcinoma, it's capable of disseminating, it's capable of metastasizing, slow, protracted, compared to high-grade serous. You know what I mean? But not an in situ. And then the Americans, Boston, right? They got a lot of wrist resections, salpingoforectomy, and they run a lot of immunohistochemistry, P53, right? In these patients, wrist resections, salpingoforectomy for BRCA. They were known to have to be BRCA. And they ran P53 immunohistochemistry. And what do they found? They found this. They found a collection or a series. You see the fallopian tube is here, the mucosa. See the cilia? You see the cilia? Well, here are cells where you don't see the cilia. They are secretory cells. They are the cells where the tumor arises. And you see more than 12. 1, 2, 3, 4, 5, 6, all. And then you run P53 and you find P53. What happened here? Tell you in 2 words what happened. Genotoxicity, I mean DNA toxicity through the vagina into the tube, right? Damage the cells, damage DNA, and then you got clonal proliferation, not enough for cancer. As a matter of fact, many of the ones sitting here may have this P53 signature, which means what? It's a precursor that doesn't necessarily get to carcinoma, and you shouldn't diagnose, you shouldn't treat, you shouldn't talk about it because it's dangerous. I mean, the risk of over-treatment. This is just the precursor lesion. Now, between this and the stage 3 high-grade serous carcinoma that we usually found, a lot of mystery. I'll discuss this a little bit later. But let me tell you that this is a true precursor of high-grade serous carcinoma. True precursor is this one. And does it occur in BRCA and also in non-BRCA? You see? And that's why I say in the pathogenesis of high-grade serous carcinoma, first is P53 and then BRCA. Why? Because if BRCA was first, you would find this lesion more commonly in BRCA, than in non-BRCA. You find this lesion You see, this P53 signature. If BRCA was first, you would find this lesion more commonly in the BRCA, but it's not. It's 50-50. 50 BRCA, 50 non-BRCA. So, I don't know. Okay, well, I'm touching it the wrong way. Haha. Again. P53. Okay, this takes me to tell you about BRCA and P53. You know, BRCA takes care of repairing. Every time the cell enters a cycle, there are ruptures of a double, and then BRCA with RAD51 repairs it. If BRCA is out of business and P53 is out of business, then you got a beautiful high-grade serous carcinoma. I mean, beautiful situation for developing high-grade serous carcinoma. Again, I don't. It doesn't like me, huh? This machine. Okay. Here are the two situations where you have hereditary and sporadic. In hereditary, you know, you already have BRCA mutation, right? And all you need is the P53. Whereas in sporadic, it's just serendipitous, right? But the mechanistic is exactly the same for a hereditary than for a sporadic. Is the game BRCA P53 for the pathogenesis of these tumors. And now we got a model for high-grade serous, not for the others. For high-grade serous, we got a model. First P53, then BRCA, and then you have what is determining the course of the disease is the copy number of DNA. You know, the copy number is what is after P53 and BRCA inactivation, you may get it. But after that, there are clones one way and the other, and it's impossible to control that because there's a very much heterogeneity in this tumor. Indeed, we in Barcelona have studied high-grade serous carcinomas and got different types depending upon this and that, and very heterogeneous. So this is the model that we have. And the question that I'm going to address immediately is, where does it come from? Does it come from the ovarian so-called surface epithelium or mesothelium through the metaplastic or change, neoplastic metaplasia during neoplasia, or is it a tubal epithelium that gets into the ovary through ovulation, for instance, endosalpingosis, or is it arising in the fallopian tube and then eventually spreading to the ovary? No wonder what you find it in stage 3, advanced stage. So, and the answer is, I don't know, maybe the three of them. As shown here in this picture from the fimbria, the fallopian tube where you have these high-grade serous, this stick, serous tubal intraepithelial carcinoma, reacting for P53, and then why not, this already my mentor, Dr. Scully, mentioned years ago, the possibility of staging these fimbria cases separate from the usual tubal carcinoma. Tubal carcinoma is very rare. How many times you find masses of tubal cancer compared to masses of ovarian cancer? Very rare. Had all been tubal origins, chances are you would find more tubal masses than. But the possibility of arising in the fimbria, which is open to the peritoneal cavity and in front of the ovary, raises the possibility of tubal origin for some of these cases, okay? Now, one thing is, this is the pathology, the histopathology of high-grade serous, tumors which are very atypical, a lot of mitosis, necrosis, and fracture of the epithelial column of cells. Now, occasionally, in the BRCA patients, young BRCA patients, the morphology is not this. It's just different. It's solid, as shown here. It is a little bit glandular, like endometrioid, glandular, right? Or transitional, like the bladder. And all of these three are high-grade serous carcinomas with P53 and BRCA, okay? So they are high-grade serous carcinoma with different morphology. And that occurs in young patients, BRCA-positive young patients, with advanced stage tumors. And this is the acronymic SET. SET is solid, pseudoendometrioid, and transitional. And these patients, young patients, with advanced high-grade serous carcinoma, young patients with BRCA positive and this morphology rarely have stick. Rarely have stick. Compared to BRCA negative, older and less advanced, which is sort of paradoxical, you know, but this is what happened, and because of these, two pathways for high-grade serous carcinoma have been proposed. One would be the stick, right? Stick in older patients with classic morphology, and those are less responsive to chemotherapy. Whereas the type I mentioned in younger, more advanced, BRCA positive, with this set, solid, pseudoendometrioid interstitial, do respond better to chemotherapy and may go through a different pathway, not the stick, serous tubal intraepithelial carcinoma. So, why am I talking about all this? Just to tell you that high-grade serous carcinoma is not one disease. As mentioned here, it's also a very heterogeneous. From the beginning, P53 BRCA, you're okay, but then immediately you get all these clones going different ways. That's the problem. Do you understand? So that's the picture I wanted to convey. It's not black and white. So does it originate in the fallopian tube? Well, all high-grade serous, only some, only BRCA positive. Is prophylactic salpingectomy indicated in all benign uterine surgeries? They have been done today, right? It's prophylactic salpingectomy, and I wouldn't oppose, right? I said, well, we'll see. But if it's not risky, why not taking? You know, you may avoid some of these high-grade serous carcinoma. I'm sure you will not avoid all, because not all are from fallopian tube origin. Now, coming back to the high-grade serous, this is a karyotype. You paint in color each chromosome and look at 6 cases of this high-grade serous. There's tremendous abnormalities of the chromosome, different colors, right? Triple, missing one arm, etc., etc. So this is chaotic. And this, no wonder this is high-grade tumor compared to low-grade. Here is the low-grade. Notice the nuclei are small and regular, whereas the nuclei of high-grade are enormous and they're a very high mitotic rate. So I will mention quickly just a couple of features about the others. I will not extend much. I would say that low-grade serous has been said that is an indolent disease. It may go for years, and it's very hard to treat, right? Surgery is the only thing that may be effective because chemotherapy is not too effective. Dr. Gershen's son has tried, and here is the precursor lesion. In this case, low-grade serous carcinoma, we can say that the precursor lesion is a serous borderline tumor. You see, serous borderline tumor is made for not invading. It's like a broccoli, no necrosis, no hemorrhage, in a cyst. If there's intracystic lung implants, whereas it's outside, then chances are you're going to have implants. And this is a histology, very non-invasive, whereas in cases of borderline which have progressed to low-grade serous carcinoma, you have invasion, as shown here. Also, here's the borderline, here's the invasive low-grade serous carcinoma. Now, why do we call these lesions implants and not metastases? Because they are small, they are superficial, and they are the beginning of the history. I mean, high-grade serous carcinoma is peritoneal carcinomatosis, which is a different picture, much worse. Whereas low-grade serous borderline is, borderline tumor with peritoneal implants, invasive implants, is just either microscopic or small macroscopic. A different picture. This is what I mean, that you have a lesion like this, running the cells, a lot of epithelial cells running through the omentum. That's an invasive implant. Why? Because it's invading. A non-invasive implant doesn't invade. It's just within a peritoneal recession or between lobules of fat, but not invading, and much less epithelial cells. Okay? And these are the two things that have been mentioned about serous borderline tumor, the presence of RAS and BRAF mutation, much more common RAS mutation, and particularly this G12V mutation, which is much associated with worse prognosis than the G12D or the wild type variant. And this has been already, the MAP kinase targeted has been already said before by the previous speaker. And let's say mucinous is a tumor that is very heterogeneous. When you have a mucinous, which is much less common, you may have, if you have a carcinoma, you have borderline and benign next to it, indicating progression from benign to borderline to carcinoma. And the music is RAS and new, LB2. These tumors, when they are found, they're usually mucinous carcinoma are found stage 1, and then the prognosis is excellent. Whereas if they are spread outside the ovary, the prognosis is much worse. I'm going to say here two things about endometrioid, that the new ARID1A, which is a multifunctional tumor suppressor gene, has changed a little bit the picture with endometrioid and also with clear cell carcinoma, in terms that you can attack TOR and PIK3CA, which are two different pathways, and block the progression of these tumors. So I will end up here by saying that ovarian carcinomas are at least 5 different diseases. And by far, the most common is high-grade serous carcinoma. Endometrioid and clear cell are less common, but we can easily associate them with endometriosis, where mucinous is a tumor that nobody knows exactly where it comes from. It has this picture of gastrointestinal in the majority of cases, although we also have cases of mucinous endocervical, Mullerian. And they are good tumors if they are found in stage 1, as usually the case in most patients. Okay? Thank you very much for your attention.
Yeah. Thank you, Professor Pratt.
I like Bombay. Oh, I like Bombay because I live in New York for many years, and it reminds me a little bit of New York. It's very chaotic, and it's not nonsense like Boston. No, it's just a no-nonsense. I think it's very chaotic, but it's very attractive, very colorful, and I had a good time here in different areas of the city every time I visited. Also, people very friendly and very alive. I come from Barcelona, which is also around the ocean, Mediterranean Sea, and is a city that has an attraction for many people around the world. So you find a lot of people in Barcelona these days, either because they like Gaudi architecture, or because they like Mediterranean food, or soccer, of course, Barca. Okay, many thanks. If you have questions, please, for related to ovarian carcinomas, either you have any question or comment. I'd like to say one, well, not question. You see, years ago we addressed the upstaging of FIGO, FIGO staging. Remember FIGO staging? We addressed updating FIGO staging. And of course, you know, somebody said, well, it's not going to be ovary. It's going to be ovary, fallopian tube, and peritoneum, right? 3. And, okay, I said it's fine for high-grade serous, but it's not fine for the other 4, because high-grade serous has nothing to do with low-grade serous, endometrial, clear cell, and mucinous, and nor mucinous have anything to do with it, nor the other 4 have anything to do among themselves and with high-grade serous. Okay, but anyhow, that's the way it came. And then more and more, after the years, we learned that, what people call a peritoneal cancer probably, in many cases, represent extension from the fallopian tube. And why? Because we had, the few cases we had of STIC, serous tubal intraepithelial carcinoma, when they recur, not immediately, but after a few years, they do as peritoneal carcinomatosis in the pelvis. And in this case, we had the specimen of wrist resection, salpingo-oophorectomy, and STIC, right? You get it? Carcinoma in the tubal mucosa, right? And then this lesion in the peritoneum. So I think that because we have not done a very systematic exam, microscopical exam of the fallopian tube, as we do, for instance, in a conization, right? In a conization of the cervix, you open the cervix, you look at the whole thing. We haven't done that with the fallopian tube in the past. So we had many cases out of the blue saying, this is peritoneal carcinoma. Well, maybe some of these cases are from the fallopian tube. Now we learn because we have. On the other hand, I would say that not all the ovarian cancers come from the fallopian tube, because it would be, most unlikely, in view of the fact that you have masses in the ovary and very rarely masses in the fallopian tube. But some do come from the fallopian tube. Coming back to FIGO. FIGO, have changed stage 3. The most significant change is stage 3, right? Remember, stage 3 was 1 micro, right? Extrapelvic peritoneum. Micro, and then less than 2 and more than 2. Okay. What is the difference between extrapelvic peritoneum and pelvic peritoneum? Do you think there's any difference? That's one criticism. Why stage 2? If this is stage 2 is outside the ovary or outside the tube, right? Because now we have tube and ovary. Ovary, tube, tube, ovary. Outside in the pelvic peritoneum. That's 2. And then if it goes extrapelvic peritoneum, it's a 3. Why? The cells go that way, circulate. So that's one criticism. Many people believe that stage 2 should be out, eliminated, and call it 3. And but there were, you do these things by consensus, and then it was voted that we should keep the stage 2. Another thing is that in stage 3 we separated these rare cases. About 8% of high-grade serous carcinoma go to the lymph node without involving the extrapelvic peritoneum, and they are associated with better prognosis. Okay, but they are about 8%. But other people complain about this greater than 2 centimeter or less than 2 centimeter. I think this is from the prehistoric era. It should be 1 centimeter, 3 centimeter, measure and report it, right? Not less than 2, more than 2 centimeter. And also the fact that, and you know better than I, that when you have one single mass, it's a much better situation than when you have carcinomatosis. And FIGO didn't pay attention to that. So I think in 2 words I have summarized. I think the FIGO 2013-14 is better than the one 1988, but it's not perfect.
So there was one comment. Anything? Any question? One question.
Excuse me, sir.
Yes.
About stick.
Stick.
Now, most of the guidelines also say for all our surgeons that try to do an opportunistic salpingectomy.
Yeah.
Most of the guidelines now say that's why for whenever you are opening the abdomen or something,
Right.
try to do an opportunistic salpingectomy.
Yeah.
That is to reduce the risk of an average female getting an ovarian cancer.
Right. I
Of
mentioned
course,
that.
for the high risk, we have risk reduction salpingo-oophorectomy.
Uh-huh.
But for others, it should be an opportunistic salpingectomy if the family is complete.
Yeah, I already alluded to that in benign pelvic surgeries, you do salpingectomy, and the million-dollar question is, how often do you find stick? Because I don't, very rarely. Dr. Amita. How often do you find stick in this opportunistic salpingectomy? Because we don't. I mean, sometimes
Bharat,
not.
you want to share our experience? We have been doing routine prophylactic salpingo-oophorectomy for BRCA mutant.
Uh-huh.
And
For
yes. No, but these
for-
are patients who don't have cancer. So you want to share our
For
experience?
BRCA is okay, but for everybody with benign surgery,
We don't actually see benign
You
cases
have?
anyway. So
in our experience, but that's anecdotal. We don't find so many. Dr. Bharat.
In routine, we're not following the SCCFIM protocol to do extensive sampling, but I believe fimbrial, so we don't do routinely in all. So for these prophylactic we've been doing, but we didn't see many. I mean, it was very less. We could see the in situ, but in routinely we don't see. It's very
Over the last 4 years, we do CFIM. You know what CFIM is?
sectioning
This is a
extensive
tube,
into-
right?
Yes,
You
SCFIM protocol.
And then
Yes.
take the fimbria like this, like a conization,
Yes.
to expose as much epithelium as possible, right? We found maybe 2 cases,
Yeah.
not too many. But I'm not talking about BRCA, I'm talking about non-BRCA,
Benign, all
sporadic,
benign.
right?
Yes.
And that's our experience. But on the other hand, some people claim that 20%. You see, if you have resection salpingo-oophorectomy for BRCA positive, how often do you find stick? 4%. But if you have high-grade serous carcinoma in older women, BRCA positive or BRCA negative, and which is in the area of the ovary and the fallopian tube, not advanced stage, early stage, you will almost always find stick. You see? And also another thing is some people say, well, maybe end up by saying that sometimes, if the stick is secondary to the cancer that is involved in the ovary, extending through the fallopian tube, and not the primary tumor. Many thanks.
Thank you. Thank you.